name is Veronica. I'm the lead antimicrobial pharmacist at Tiskent, and I've been working with Dharmisha at the Thames GMSA for the past year and a half. And I'm going to start the presentation, then I'll hand over to Dharmisha, and we will do a little bit of handovers to each other so we can break up a little bit the session in case anybody has got any questions. However, we will open up for questions at the end of the session as well. So the aims objectives for today is we will have a little brief about how aminoglycosides work, the mechanism of action, and how they can cause toxicity and the genetic cause of these, the current available tests that we have in the UK, and I'll be talking about the pilot study, and Dharmisha will be talking about considerations to think if anybody's thinking about implementing any of the testing in their sites. I'm going to go into the next slide for some reason. Thank you. So in regards to what are aminoglycosides, they are bactericidal, as most of you know, and the most common aminoglycosides used in the UK are gentamicin, amikacin, and topramycin. So they are active against gram-negative infections and some gram-positive microorganisms. Aminoglycosides, they are not active against anaerobes, and this is because their uptake across bacterial cell membranes depends on the energy derived from aerobic metabolism. So consequently, they have markedly reduced activity in areas of low pH and oxygen tension. So, and from a mechanism of action perspective, they inhibit the translation of the messenger RNA by binding to the bacterial 30S subunit of the ribosome. This is an irreversible binding, and which causes the misreading of the codons along the messenger RNA. This misreading originates an error in the proofreading process on translation, and this leads to improper protein expression, which induces the bacterial cell death. And we all know that aminoglycosides can be nephrotoxic, and in most cases, this is reversible. The acute kidney injury induced by aminoglycoside is due to the acute tubular necrosis, which explains why we need to check the therapeutic drug monitoring and the renal function. But they can also cause hearing impairment and vestibular problems. And any of those signs are things that healthcare professionals need to think about: any new tinnitus, dizziness, poor balance, hearing loss, oscillating vision. The toxicity is associated with prolonged use and is secondary to drug accumulation in the inner ear. So while toxicity can be transient in some cases, it can also be irreversible. And regular audiometry monitoring is desired, especially if we are talking about a duration for any period longer than 7 days. And it is advisable to have a baseline audiology test if possible. So most of the ototoxic substances are found in high concentrations in the inner ear and cause hearing loss by damaging the cochlea. In particular, the auditory hair cells and the stria vascularis. We have a picture here in the right-hand side of the cochlea, which is the hearing and balance organ. It contains specialized sensory cells called hair cells. The sound vibration makes these hairs move, and this will automatically induce a mechanical stimuli into an electrical signal that is carried to the brain by the auditory nerve. So aminoglycosides, they appear to generate free radicals within the inner ear with subsequent permanent damage to sensory cells and neurons, resulting in permanent hearing loss. Streptomycin and gentamicin are primarily vestibulotoxic, whilst amikacin and neomycin have been found as cochleotoxic. We have 2 mutations in the mitochondria, in the human mitochondrial 12S ribosomal RNA gene, that they have been previously reported to predispose carriers to aminoglycosides-induced ototoxicity. But how how does occur? How does this occur, this ototoxicity? Well, the mechanisms of the genetic variant, we will be talking about the M1555A2G, and Dharmisha will be explaining to you a little bit more about this genetic variant. But this mechanism leading to greater toxicity has not been fully established. But the following three mechanisms each contribute to aminoglycoside-induced toxicity after systemic administration. One of them is the drug trafficking across the endothelial and epithelial barrier layers. Another one is sensory cell uptake of these drugs, in which aminoglycosides accumulate in lysosomes within hair cells, and they will rupture and they will lead into hair cell death. And the third possibility is the disruption of intracellular physiological pathways where aminoglycosides can bind to alleles of the human 12S mitochondrial ribosomal unit, which is encoded by the mTRNR1 gene. So Dharmisha's got a really nice picture in the next slides that is she's going to show you the similes between the human ribosomes and the bacterial ribosomes. And I'm just going to hand over to her, but in case anybody has got any questions, you can ask now, or otherwise we can carry on. I think we can carry on.
Okay. So I am going to go through the mitochondrial DNA mutation, and the one that we have been mentioned about is M.1555A to G. And you're probably wondering what that means, and I'll explain that to you in the next few slides. So mitochondrial DNA, it's something that we've heard about before, possibly in the news when King Richard III remains were found in a car park. And mitochondrial DNA has originated from aerobic prokaryotic cells, probably by the purple cell bacteria way back when evolution was at the very beginning. And it was engulfed by anaerobic eukaryotic cells. So now it's synergistically part of us, and it is involved in our functioning and producing energy. So it explains why mitochondria have their own ribosome. So it's essentially its own bacteria right at the beginning. But this particular part of the DNA is inherited from mothers only. So it's from the maternal line. So normally we inherit 2 copies of genes, one from the paternal side, one from the maternal side, but the mitochondrial DNA is inherited from the mother's side only. And therefore, if there are mitochondrial mutations, it will be inherited from mother directly to her children. So it's quite a powerful tool. When King Richard III was found in the car park, they wanted to identify if it really was King Richard III, and they were able to go back right from the person who is alive right now, Michael Ibsen, right back to his maternal line to actually then link it to Edward III. So it has a powerful component when it comes to hereditary. When it comes to aminoglycoside-induced ototoxicity, this pattern was also discovered within families from the maternal side. And essentially they had a group of families, some families who had hearing loss and others that didn't. And those that did had this variation called mitochondrial 1555. And it was linked to aminoglycoside usage. And this is a paper that is from 1998, but this particular variant linking it to aminoglycoside was found as early as 1993. The thing about mitochondrial DNA, which makes it a little bit more different, and I'm going to just talk about a genomic consideration, is that in women, they have a set number of eggs, and within those eggs, there's a set number of mitochondrial DNA, which is inherited from the mum before. And however, it's not equally distributed in terms of the particular variants that are inherited. So you could have some eggs which don't have the variant or have low levels of the variant, and others which have greater levels of the variant within the DNA. So this is simply stating that there's different levels of penetrance. So you may have some individuals that may be exposed to aminoglycosides and they may have a milder form of hearing loss, such as tinnitus. But then there may be others that have this particular variant with a higher penetrance, which means that it's more exposed within their DNA. And that means that if they have an aminoglycoside, they have a greater risk of deafness. And sometimes after one dose of aminoglycoside, they can have bilateral hearing loss. And so you can have different levels of mutational load. So you can have high mutational load in one particular egg and that gets inherited, or in another egg, it will be a low mutational load, and where the child could be clinically unaffected, depending on the level of penetrance. It should be noted that when the mitochondrial DNA is being tested, it only tells you whether the result is positive or negative. It doesn't tell you the level of penetrance, so you don't know what the clinical outcome will be after an aminoglycoside has been given. So that's just one consideration to keep in mind. So what is mtRNR1? So I'm going to break it down in terms of the way that it has been depicted in reports. So mtRNR1, that is the gene symbol. So that's how the gene is described when they look at it. The M means the mitochondrial region of the gene. That's essentially what that means. And then it's followed by a dot and then a sequence of numbers. In this case, it's 1555. And this is the position within the mitochondrial variant. So within our DNA, you have different genes and they all have different position, and each position has a number, and this is 1555. Adenine is represented as A, so that's a nucleotide. And this is a reference nucleotide. And this is present in a majority of the population. So this is based from the reference genome that was done as part of the Human Genome Project. In this particular variant, adenine is substituted, so that's what that greater than symbol means. It's substituted for another nucleotide called guanine. So this is the nucleotide that has been substituted, now present in the gene, and that is what's being tested for. And this particular variant happens in 1 in 500 individuals within the population. So it is a relatively rare variant. So this occurs within the mitochondrial DNA, which is circular DNA and consists of 37 genes. So it's quite a small part of the DNA. So what does this mean? So as Veronica mentioned, aminoglycosides cause bacterial side effects through inhibiting the protein synthesis of the 16S rRNA of the bacterial 30S ribosome. Within humans, we have a 12S subunit, and that's coded for by this mtRNR1 gene. But it's very similar in structure and composition to the 16S RNA DNA that's found in bacteria. So when there is a mutation that occurs, or a gene change of where the A is substituted for a G, this means that the human part of the gene actually now resembles that of a bacterial subunit. And therefore, when a person is given an aminoglycoside, it doesn't distinguish from a bacterial to a human ribosomal subunit. And therefore, that's causing the hearing loss, which can occur in severe cases after one dose at normal therapeutic levels. So on 7th of January 2021, we were at the peak of COVID, an MHRA alert came out, and they conducted a safety review in 2020. And it was following concerns received by the impact of mitochondrial mutations leading to the risk of ototoxicity with aminoglycosides. So they conducted an epidemiological studies, and it showed that within the population, there was about a prevalence of 0.2% of this gene change within the general population. So they suggested that clinicians should follow local guidelines on mitochondrial screening in patients where there is a maternal history of deafness, because as I said, it's inherited from the maternal line, or those that will need or require aminoglycosides as part of their long-term treatment plan, or where they've had prior exposure to aminoglycosides. So that came out in 2021. Now, there are guidelines available. So in March 2021, there is a global consortium called the Clinical Pharmacogenetics Implementation Consortium, based mostly in the States, but it is a global team, and it consists of pharmacists, pharmacologists, scientists interested in pharmacogenetics. And they produced a guideline on this particular variant for aminoglycosides and the clinical applications that it could happen in day-to-day routine care, and what clinicians should think about. So these guidelines don't say whether you should test, it just assumes that people are testing, and these are the following guidelines that you could follow if you wanted to implement it within your institution.
So what do they say? So this is just a quick summary. I mean, it is a good guideline to read. So if you're interested, please have a look. The link will be, I can provide the link after the presentation. But essentially it says that you'll do preemptive testing for this gene variation, the mitochondrial variant. And if it's not detected, you'll follow your standard care of treatment. However, it should be noted that aminoglycoside-induced hearing loss will not completely be negated because a risk may still be present, as different mechanisms may also be involved in causing aminoglycoside ototoxicity. Additionally, there are other variants which we do not test on the NHS, but can also lead to hearing loss. So it's not saying that it's going to completely exclude if you do not find this particular variant detected. If it is detected, you will follow your local antibiotic guidelines, but essentially you may feel that the patient will fall into 3 different categories based on the clinical presentation of your patient in terms of the infection risk and the safety. So 1, it could be safe to avoid the aminoglycoside completely, and you'll give the alternative. Or the infection risk indicates no suitable alternative is present, but you do probably need to give a shorter aminoglycoside course. That's may be recommended. Or in some very minority of cases, the infection risk indicates that there is no suitable alternative and that you'll need a full course of aminoglycoside. And these will be the MDT decisions that will probably be made within your institution, and also having a risk-benefit conversation with the patient in front of you. So that gives you a bit of a snapshot. So how is this commissioned on the NHS? So it's commissioned via the National Genomic Test Directory, and there are 2 test directories available. So we've got one for rare inherited diseases and another for cancer. So this particular genetic test is placed within the rare and inherited diseases, and it's coded under R65. The aims of the National Test Directory is to ensure that the directory reflects the latest technological developments and scientific advances, because genomic technology is ever evolving and improving. It's also to ensure the fair and equitable access of genomic testing across England and to ensure best value. But it's also there to help our understanding of the clinical utility of genetic testing within clinical care for our patients and within a clinical pathway. So really thinking about the end-to-end pathway of testing. So within the test directory, the R65 has an eligibility criteria, and this is stated here. So this test is for individuals where there's significant exposure to aminoglycosides posing risk of ototoxicity. So this indication would be relevant to individuals who have a predisposition to gram-negative infections. And so this is where you'll have a cohort of patients who are more likely to get gram-negative infections and more likely to be treated with aminoglycosides as part of their treatment care. And examples that have been given are bronchiectasis and cystic fibrosis, and other examples are structural void in genitourinary tract disorders. And the other indication is where individuals who have already had a hearing loss and you think they've been exposed to prior aminoglycosides, which has led to them having some form of hearing loss. And in those patients who fall into category 2, they might be referred through via an audiologist pathway, and they'll probably do other tests as well to exclude other different differential diagnosis. In April 2023, there is reflex testing has been confirmed for cystic fibrosis. So this will slowly become implemented over the next few years. But essentially, when an individual has been diagnosed with cystic fibrosis, they will then automatically test for this particular variant. So it's there in the clinician's note, ready to go. So how do you request the test? So there are genetic referral forms. So for North Thames, we have it present on our North Thames Genomic Laboratory Hub website, and this is what the form looks like. And you have to complete the form, and there's in the box here where it's got clinical indication, you have to put the reason for referral, so that you're testing for this mitochondrial variant. Patient's going to be exposed to aminoglycosides as part of their treatment. We have I have listed all the different GLHs here and their forms, because I know that though this is for North Thames Education Training Session, I know that I've opened it wider across England, so that if you're in one of these regions, you can access the form here, and so you have an idea of what they look like.
Consideration. So we had a discussion with the North Thames GLH when we first came across this test a couple of years ago because we wanted to know more about it. The turnaround time for this is not short. It's 10 to 14 days within North Thames, and in other regions it can be as long as 6 weeks. So just check with your local GLH on the turnaround time. Now, when we think about antibiotics, we want to give them immediately. So you may not have the time to wait. And that's the reason why the eligibility criteria states where you can actually plan the aminoglycoside. So you have the ability to plan before you treat. They state it is for individuals who have prolonged or recurrent aminoglycoside, so that matches with the eligibility criteria. But they do say that if a patient, particularly an adult, has been treated with an aminoglycoside and hasn't had any hearing loss at all, you probably don't need to prioritise testing them first. If it's a child and you especially in cystic fibrosis, you probably just want to test. But that just gives you an idea of how you may want to prioritise patients when you are thinking about implementing this within your local institution. Adults who are suspected of hearing loss, which could be due to aminoglycoside, it is actually preferable to refer to an audiologist because you may not know the actual reason. It could be aminoglycoside, it could be something different. So in that case, it would be quite good to touch base with your audiology departments and what their referral pathways are and what kind of patients they see. Patients who are established on cystic fibrosis and bronchiectasis, where they haven't had any audiology problems, especially if they're reached adulthood, you may feel like you don't need to test. But I think for cystic fibrosis, you may want to, just so you have the test there in the patient notes. But that's up to individual institutions as to how they want to prioritise. So that is about the background of the genetic test and what test is available on the National Test Directory. And I'm going to hand over to Veronica again to discuss more about the point of care testing, where there's information that's come out, but it's not an NHS commission test. So over to you, Veronica.
Thank you. You know why I can't move to the next page?
Do you want to try again?
Yes. Okay. So a year ago, the news were showing information about the NHS and genetic testing babies, and all that was coming from the PALO trial, which is what I'm going to be presenting to you in a second. I'm going to the next slide. Okay, so PALO stands for the pharmacogenetics to avoid loss of hearing, and the study first began in 2018. It was funded by the National Institute for Health and Care Research for Innovation Programme, and it was supported by the Biomedical Research Centre in Manchester, in partnership with the firm GenDrive, which is also based in Manchester, and the charity Action on Hearing Loss. It was a prospective observational study based on the 1 in 500 prevalence in aminoglycoside-induced ototoxicity and the unacceptable delay of testing patients with sepsis with the current genetic testing for the M1555 variant, because this genetic variant was established in 1993, but technology had not been available to rapidly test for the variant on those case of scenarios for urgent need of treatment. The methodology used was detecting the M1555 variant via the GenDrive point of care test, which is done from a buccal swab sample during routine baby care. So the system was integrated into the clinical pathways at 2 large neonatal centres in Manchester, although only one centre hardly recruited any patients due to the pandemic. So let me bring you this is how the flow diagram, this is the flow diagram demonstrating the admission, the testing, and the prescribing process in the PALO trial. The time scale is seen in the left arrow down, and the time that the decision was made to prescribe antibiotics represents the time 0. If antibiotics were not prescribed, then time 0 is represented by the time of admission. As you can see in the flowchart, the exclusion criteria was for babies requiring antibiotics immediately. But this was determined by the admitting clinician with already established intravenous access. However, if there was no IV access for the baby, then this may provide time to run the assay and patients could be included. So if the M1555 variant was present, an alternative antibiotic based on a standard protocol was administered, and babies were followed up for further genomic testing and parents for counseling. So here we have the results, and we can see a range age of 2.5 days old with a minimum of 0 and a maximum of 198 days old. The mean gestational age at time of delivery was 37 weeks. And we can see that only 2 parents didn't give permission to participate. You can see that on the left, didn't give permission to participate in the study. And a total of 749 babies were recruited, in which 526 received antibiotic therapy, but 102 patients had to be excluded as the genotype test had failed or the test had been missed. So there was a total of 424 neonates who were prescribed aminoglycosides and had been tested successfully, and 3 babies were identified with an M1555 variant. And these results, they were confirmed by Sanger sequencing, which is the test that is taking a little bit longer, the test that Dharmisha was talking to you about, the one that it is commissioned by the NHS. And that confirmation is bringing us to a higher prevalence than the one initially expected of 0.21 into 500. We have a higher prevalence. However, this is a very small study to make any conclusions. But there were 5 false positive results. There were no false negative results, and as such, the assay had a real-world analytical sensitivity of 100% and a specificity and accuracy of 99.2%. The time required for the taking sample and having the results by the point-of-care test was 26 minutes. And I'm going to talk about the limitations of the study. If I can go into the next slide. So, as any studies, the PALO also had limitations. The recruitment was mainly set up from a single site. And both sites, they engage, although it was initially for both sites, but as I told you, because of the pandemic, only one was recruiting main babies. Both of them, they were heavily involved in research, and they have research activities on a regular basis, and they have extensive experience with implementation of new technologies. So this experience probably facilitated the delivery of the PALO trial, but should be considered if anybody is trying to attempt to generalize any findings to other centers, that they may not have equivalent research or implementation expertise. Information about ancestry or gender from a prevalence considerations, but it has not been identified. Although we believe that this was an equitable test because we can see that different ethnic groups, they were included for testing. Furthermore, antibiotics prescribing practices show considerable variation, both in the rates of prescription and the ages chosen, and also within and between countries as well. As such, the utility and the cost effectiveness of this new test of the M1555 A2G will be context dependent. Another limitation is a consideration that we thought later on after after being in the stakeholder panel, and it was like the main point of care test policy holder is normally the lab or the micro department, and we don't know whether they were consulted for any requirements from a traceability perspective. So, as I told you, Dharmisha and I, we were heavily involved within the stakeholder panel for the NICE evaluation, and we are pleased to see that the NICE has recently published on the 30th of March this year, 2023, the current recommendations for this GenDrive kit, and they are recommending that it can be used while further evidence is generated as an option for detecting the M1555 A2G variant and to guide antibiotic treatment when the antibiotics aminoglycoside in a neonatal setting. And this is to prevent hearing loss, obviously, and it will be only in places where they are already using aminoglycosides. NICE is also recommending that the healthcare professionals, they should consider and they should tell parents about the possible implications of the positive test results for the baby and their family at any appropriate time in order to give support and information. And this is mainly because the positive results from the gene drive test, it is required, they should be confirmed by laboratory testing. So you may have, although in the initial PALO study, all the tests that they were positive were confirmed as positive by Sanger sequencing, and that there must have, we need to think about the considerations if you have a false positive or false negative in any moment of time, how the information is being given to the parents as well. Also, the recommendation is conditional on further evidence, and if anybody wants to think about bringing this test into their neonatal units, they need to be thinking about having a robust way of generating that evidence on how the test affects the time to antibiotics, given how the test affects the prescription decision making and any technical performance and accuracy of the test as well. So the GenDrive system screens, this is how the GenDrive looks like, and that screen shows the results, and there is no paper involvement. It has a storage of up to 1,000 results, and data can be transferred using Wi-Fi and LNA connections if needed. The operating conditions are between 16 to 30 degrees, and the mtRNA test kits, they can be stored at temperatures between 2 to 30 degrees, so a really wide range of temperatures. There are still the key uncertainties is something that we also need to remind, because the evidence of the technology, there is the only publication that we have is what we found in the pilot study with the GenDrive testing, and the one expert said that it could be complex to implement the test, and the recommendation was to make a formal economical analysis for the sites or whoever was thinking about implementing that. The GenDrive ID kits cost around £100. It can be a little bit more expensive if considering any control test or any sort of extra training, and it's been evaluated around £130. So does this mean that genomics can reduce cochlear implants request? So, well, most of the major deaf organizations support cochlear implants as it's one of the choices available for families with a deaf child with a profound or severe hearing loss. So this technology can show us if there is a reduction of cochlear implant requests. So what we see is that currently around 1,260 people per year in England have cochlear implants, and this number is meant to be increased in this actual financial year after the whole COVID is part of business as usual, and it is expected that we would probably treat it up to nearly 3,000 patients with a cochlear implant. From the CRI data, we know that only 7% of the total deaf school children in England have cochlear implants. And the cost of a cochlear implant surgery is estimated around 60k per patient. So obviously, this technology coming into the market where deafness can be prevented, there is a willingness to implement this. However, we require a multidisciplinary approach, and we have listed considerations that Dharmesh is going to talk to you about, and something very important. Over to you, Dharmesh.
Take myself off mute will be helpful. So I'm going to go to the consideration of aminoglycoside pharmacogenetic testing. So we have, most of us are pharmacists here, but even as clinicians, we have an idea of drug response in terms of pharmacokinetics and pharmacodynamics. And when we implement elements of genetic data in there, in order to get something that's truly personalized, there are a few governance things that we do need to think about. The first is education and training, which is why we're all here, making sure that we will have the necessary understanding before we implement a pharmacogenetic test. And this will have to be multidisciplinary to make sure that everyone's at the same genomic literacy level. Quality control is also quite important, especially when you're implementing a new technology. We have the test on the NHS, which can be used to confirm any positive or negative results that come on from the gene drive, for example. So that needs to be taken into consideration, and that goes for all pharmacogenetic testing. The delivery and how that is done within your clinical area will probably look different from one institution to another, but how that will fit into a pathway so it doesn't slow anything down is important. And that goes through to reimbursement issue, making sure that you have the necessary funding in order to implement a new service, particularly around pharmacogenetics. In terms of when you implement it, clinical guidelines will probably be needed, or to update some clinical guidelines to make sure that everyone knows what they're doing, especially at junior level, and when you have new staff coming in working in particular ward areas. Economics and cost-effective data is important, and I think if you are implementing a new piece of technology or a new pathway, it would be good to have that element into thought about if you're doing a research project, for example, because one of the elements in pharmacogenetics is that there's very little sometimes cost effectiveness data. Privacy issues also need to be thought about. I think in terms of pharmacogenetics, it's always considered as a safety test, but I think it's about keeping patients' genetic information safe, just as we do with any form of personalised, well, any form of confidential data that we use within the NHS. And all of this needs to be implemented thoroughly and done properly before you can really fully implement personalised medicine. In terms of things that are particular to this particular test, we need to just be considerate of the turnaround time. Within North Thames, as I said, it's up to 10 days, and in other GLH areas or GMSA areas, it can be up to 6 weeks or longer. So the one that we have in the NHS is not a point of care test, and so if you wanted to implement something in a NICU centre, then you'll have to think about whether the point of care test is something that you would want to do. There are other variants that have been reported. So these two variants here on the second bullet point are also associated with aminoglycoside-induced hearing loss, and there may be different levels of prevalence within different ethnic groups. So that needs to be considered. And a lot of the pharmacogenetic data in general tends to be based on white European populations. So when you're reading data, just to be mindful of the ethnicity and does it actually reflect the population that you're serving. Guidelines, a national approach here will be required. Veronica and I have been working on some guidelines within North Thames that can be utilised, and that essentially lists out main governance questions that an institution will need to think about. So hopefully, once we finalise that, we'll be able to share something to everyone. Education and training, and this also includes the patient and the families as well in terms of genetic counselling. How much information do you want to give a patient? What are the risks that they need to be aware of, particularly when it comes to family history? So if you've noticed that there is hearing on the maternal side and you have a patient that you're treating with aminoglycoside, is that something that you need to consider? Drugs and therapeutics committees. I think when we have new drugs or new things that go through a trust, it goes through our drugs and therapeutic committee. So if you're doing something in terms of a new technology or a new pathway that includes pharmacogenetic testing, do you have the right expertise around the board to ensure that you're thinking about the right kind of questions when it comes to pharmacogenetic testing? Interoperability and confidentiality, and I think this is more about how or where should the test be stored. So if you have a child that you've tested for this particular variant, they're going to grow up and live somewhere else. So how do you make sure that that particular genetic information actually follows through? So in this particular case, there is a SNOMED code for this particular gene variant. Population testing, so I've mentioned ancestry, is the data inclusive of the region that we are serving. If this is a brand new clinical pathway that you're implementing, especially if you're using a novel technology, I think it'd be really worthwhile to utilise it as a research project or do a service evaluation. So you have data that you can then publish and share with your colleagues so that everyone understands how individual organisations are actually implementing the test. And that will allow more shared data and also allowing us to look at different ways that different institutions have implemented the test. Because not, as I said, it may not be similar in every hospital, because we all have our own nuances when it comes to our institutions. So if you want to know more about this pharmacogenetic test, in North Thames, I'm your lead pharmacist, so I can support you and help you and reach out to our North Thames Genomic Laboratory Hub, which is based at Gosh. But across England, we have other pharmacists will be able to support you across the region. So if you're not sure who your lead pharmacist is, let me know and I can direct you to the right person. And each of us are all pharmacists, and we're able to support and help and guide, and also reach and link you with the respective genomic laboratory hub leads, because I'm aware that our attendance here is more than just the North Thames.